Welcome to Glioblastoma, A.K.A. GBM, a podcast brought to you by the Glioblastoma Research Organization, highlighting stories of GBM warriors, caregivers, medical advisors, and more. Welcome to Season 3 of our podcast, where we delve deep into the world of glioblastoma, also known as GBM. Join us as we navigate the complexities of glioblastoma with expert insights and heartfelt narratives. Please remember that the information presented in this podcast is for educational and informational purposes only. It is not intended to treat, diagnose, or prevent any disease, and you should contact your medical provider or healthcare team with any questions. Plus Therapeutics is developing a novel treatment for recurrent glioblastoma patients. Their targeted radiotherapeutic has the potential to deliver a single yet highly powerful radiation dose directly to a tumor without damaging healthy tissue or causing significant side effects. They are currently enrolling patients for their NIH-supported ReSPECT GBM clinical trial. For more information on this recurrent glioblastoma trial, please visit respect-trials.com/GBM. Dr. Mark Hedrick, welcome to the Glioblastoma, A.K.A. GBM podcast. I am so excited to have you on the show today to talk about Plus Therapeutics and everything that you guys are doing with the new research that you're working on and the new trials that you have going on. So welcome to the show, and thank you so much for joining me.
Hi, Amber. Thank you. Happy to join you.
I would love for you to first introduce yourself and then go into telling us a little bit about Plus Therapeutics' mission.
Sure. Well, again, my name's Mark Hedrick. I'm the president, CEO, Plus. By background, I'm a physician, general surgeon, vascular surgeon, and craniofacial surgeon, formerly at UCLA. Left my practice a while back and been in technology development, pharmaceutical development for the last 20 years. So that's sort of my background, an MBA along the way. And Plus really started in 2019, and we had the idea that targeted radiotherapeutics for central nervous system cancers had tremendous potential for what are really tough medical problems and largely unmet medical needs, as you know, and probably your audience knows. And the reason we thought that is that central nervous system cancers are very radiosensitive. By and large, they tend to respond well to radiation. The problem is getting enough radiation to the tumor and not getting it to the normal tissues like the bone marrow and the gastrointestinal organs that tend to be affected when high doses of radiation are given in sort of a diffuse, non-targeted way. So we felt like if we could marry high doses of radiation, but go directly to the tumor or the at-risk tissue, we could talk about what that means in a minute, then we can get better outcomes than we can get with current therapies. That was the idea behind it. And since then, we've done a number of business development transactions to build up a portfolio of technologies that allow us to do just that.
Can you talk a little bit more about targeted therapeutics and how targeted radiotherapeutics work?
Sure. So there's kind of two words there. There's targeted and then there's radiotherapeutics. And I'll take them individually and then merge them back together. So targeted in simplistic form means you want to hit the bullseye meaning the tumor or the area around the tumor that's at risk for causing a recurrence, which is common in glioblastoma, by the way. And there's several ways to do that. So you can put a chemical on the drug that attracts it to the tumor and binds directly to the tumor and tumor cells that deliver it. You can deliver it through devices and other things that help get it there. Or you can do a very narrow ray beam that comes inside and out, but that's a problem because you're going through normal tissues with a ray beam. The tumors in the central nervous system are really problematic because of where they're located. The brain is a tough organ to get to. It's surrounded by the skull and the face. The anatomy is really difficult, and all of it is very important. There's no part of the central nervous system of the brain that you can't really do without. It's all very important. And if there's a problem it causes a series of symptoms or problems for the patient. So you have to be really respectful of the anatomy. So the other thing is that in targeting, there's something called the blood-brain barrier. It's a technical term, but people that follow glioblastoma in these patients or caregivers may know about that. And only about 2% of drugs go past this blood-brain barrier. It's there as a protective mechanism to protect your brain and spinal cord from bad stuff that's circulating in your blood system. So it's there for a reason, but it also is an impediment to getting any kind of drug, targeted radiotherapy, whatever, in there. So the targeting strategies for the central nervous system have to be really tailored to that organ and tissue. So we use a couple of different strategies depending on what the tumor is. We could talk about that in a moment. In terms of radiotherapeutics, the other half of the equation, radiation as a cancer killer has been around for decades, very commonly used. I think about a very high percentage, I don't know the exact number, I can't remember exactly, but receive some sort of radiation for the treatment, whether it's breast cancer or CNS cancer or lymphomas or other kinds of cancers. They're very commonly used for patients. But over the last 10 years or so, people have recognized that, wow, you can use unique strategies to get the radiation to the tumor, and you can concentrate the radiation to the tumor. And that radiotherapeutic is really so that's sort of a drug that delivers the radiation. And there are different kinds of sources of radiation. And we use a particular one that we think is ideal for the CNS, but there are other types of radiation that are used in other cancers, like cancers of the prostate or the pancreas or other cancers. So targeted radiotherapeutics.
To develop the drug, though, like when working to develop it, how did you, I guess my question is like, how do you decide which radiotherapy you want to use? I mean, you said like there are different options and different types are used in different cancers. Like what makes you and your team say like, hey, this is the one that we're going to use, and how do you proceed with deciding to do that?
Yeah, it's a great question. So I have to begin by crediting the academic inventors at the University of Texas, MD Anderson, that came up with some of this core technology that is now in the drug that we have in clinical trials. But we kind of looked at, and they looked at, okay, what are the unique problems with treating central nervous system cancers with radiotherapeutics, and then what sort of properties need to be in the ideal drug to treat those. And so it started with the radioisotope. That's the source of the radiation. And we use a radioisotope called rhenium 186. It's very unique, but it has the ideal physics. It's a sort of they're complicated, unique set of properties that relate to the physics of rhenium 186 that make it ideal for the central nervous system. How far the radiation goes out, it's very contained and precise. It's long enough to kill the tumor, but it's short enough not to affect other organs and tissues, which is a problem with external beam radiation that's commonly used today. It has two kinds of radiation. It has a cancer-killing radiation, but it also has an imaging radiation. And this is super important because we can know at any point in time where the drug is and how much radiation it's giving to the tumor. To think about other drugs, you don't know where your aspirin is when you take it, and you don't know if it's getting where it's supposed to go. You know, if you feel better, but you can't look at the body and tell where it is. We can tell very precisely where this is and how much of the affected part of the tumor, which is of the drug, the radiation, is getting to the tumor. So that's really important. So that's the radiation source, rhenium 186. The other thing is that how do you get it there and keep it there? One problem with radiation in patients or families of patients that have had glioblastoma that have been treated with radiation know they have to go back to the hospital, for 4 to 6 weeks, once a day, 5 days a week. So you have to get multiple fractionations of the radiation. So you get little bitty chunks of radiation over multiple days that add up to, a dose that's effective. We formulated the rhenium in lipid vesicles called nanoliposomes. So it's nanotechnology. It's formulated that when you put those nanoliposomes into the tumor or the tumor area, they stay there until all of the radiation goes to the tumor, and then they're metabolized. So it increases the time that the radiation is on the tumor. And in fact, it's in a brain cancer, it's there for several weeks. Single administration, one dose, not multiple doses over multiple weeks. It's single dose. In glioblastoma, the radiation goes right to the tumor, or the key area around the tumor, delivers all the radiation, and then it's normally metabolized. So the nanoliposomes are a critical part of the system as well. And then another part of the system is how we do the targeting. There's software and neuronavigational hardware in the operating room by the neurosurgeon might use that allow us to target it very precisely within about a millimeter of where we plan to put it. So it's the targeting technology, the liposomes of the rhenium, really makes an ecosystem that allows us to do what we couldn't do just a few years ago.
Interesting. And that leads me to my next question. I want to talk about the ReSPECT GBM trial, but also prior to that, I want to understand, for those that are listening as well, to explain about the trial. But I'm also curious, when you're talking about these like radiotherapeutics, can you talk about the process in which the actual trial is conducted? Like, let's say I'm a patient and I decide I meet all the criteria, I decide to join the trial. What does the next step look like? And like, how does, like, again, like the dosage look like? And what is the entire process of working with targeted radiotherapeutics look like?
Yeah. So let me talk about what the journey for the patient and the family look like, because it's so very different than chemotherapy or external beam radiation, which are sort of the mainstays of treatment. And we're just talking about glioblastoma. We treat other central nervous system cancers as well, but just focus on glioblastoma for a moment. So when the patient in the trial, or when this is approved, hopefully, when they recur, most patients that are diagnosed with GBM, they almost all will recur, but after their initial round of treatment, they get serial MRIs every 60 days or so. So the doctors will look at those and they'll see that the cancer's recurred. So we're just focused today on just the recurrent GBMs. One day we'll do the primary GBMs and brain mets, and the other in pediatric brain cancers. I'm just talking about recurrent GBM right now. On those serial MRIs, the doctors will identify a zone at risk for recurrence. Then we get involved. The doctor says, the neurosurgeon typically will call us and say, look, this patient's coming in. I'm worried they have a recurrence. If they do have a recurrence, I would like to treat them with this product, with rhenium obisbemeda. That's the chemical name for the product. So they call us. We make the drug. The patient gets admitted to the operating room. A treatment plan has already been put together. So while we're making the drug, we work with the neurosurgeon to develop a treatment plan specific for that patient. That treatment plan is loaded digitally in the computer system in the neurosurgical OR. So the patient gets admitted, goes right to the OR. The doctor does a biopsy of that area that confirms that either the tumor's there or it's not there. If it's not there, that's good. The patient can go home. If there is a recurrence there, then the drug is available, and the doctor will put up to 5 very tiny catheters into the tumor area and sort of anchor them. So for 24 hours, the patient will have these 5 little delicate catheters coming out of the tumor area, the area around the tumor. They'll go back to their room and recover from the biopsy and the catheter placement, we've really never had a problem with that. Patients do really well, tolerate that very well. And then the next morning they go to nuclear medicine, and they lie on a table, and there's something that looks like a CAT scan on them, and they lay there for maybe 2 to 4 hours. And we actually infuse the drug through the 1 to 5 catheters, depending on the tumor. And then once the drug's infused, the catheters come out. It's not painful at all for the catheters to come out. They can do that in their room. They don't have to go back to the OR, and then they go home. That's the treatment. So it's really at least a night in the hospital, and then that's it. And then the patients are followed over time with MRIs. And then also we do something called a SPECT CT, which reads the radiation coming out of the radiation liquid that's in and around the brain, and we just monitor it to see how much radiation the tumor is getting. Is it going according to plan? And then we monitor the patient for any future recurrence.
Interesting. I guess if someone's hearing this, they might say, you're getting X amount of catheters placed in the brain, and then you're getting dosage of rhenium 186, and then you go into a CT like machine for, let's say, 2 to 4 hours. How is the risk of radiation induced issues like mitigated?
So the way we mitigate it is we only put the radiation to the tumor.
Okay.
So there's no issues with systemic toxicity. We just haven't seen that, and we haven't seen the normal part of the brain react negatively. It really is the tumor, and when we do the case planning, we see all the neural tracks. We can see that with the imaging software. We can see where the speech centers are, the motor areas are, and see the relationship of the tumor to those very important parts of the brain. And so our case plan contemplates putting it precisely to the tumor, but also the infiltrative margin. And if patients know anything about the biology of brain cancers, the problem is the tumor, but also about a rim of about 1 to 2 centimeters around the tumor that you can't resect. And it looks pretty normal on imaging oftentimes, but we treat that as well. That's one of the key unique aspects. But the normal brain reacts well. The tumor reacts very poorly. It dies, which is what you want. And so that creates sometimes some swelling. And so the patients get steroids. It's pretty normal in brain surgery to get steroids. So the patients routinely get steroids, and that's pretty much it. Patients do really well, and it's been remarkably safe. There's something in clinical trials called a dose-limiting toxicity. So as you increase the dose, sometimes you increase the dose so much, you're trying to figure out what the right dose is. We haven't had any dose-limiting toxicity. It's been remarkably safe, given the amount of radiation we're putting in. And this is really a key point. The amount of radiation we're putting in is 10 to 20 times what you can get with external beam. External beam radiation and glioblastoma is the gold standard for radiation. And it's actually the best killer of glioblastoma cells, better than chemo, better than anything. It's the best, and we're giving 10 to 20 times the amount. And that's why I think this technology's got a lot of promise.
When you're talking about, the fact that this is treating recurrent glioblastoma, typically I feel like someone would think, okay, I have a recurrent tumor, let's take it out. But you guys are saying, keep it in. We're going to conduct the treatment and the radiation on the tumor without resecting it with just a biopsy. Why is that?
Well, first of all, some tumors aren't resectable, or they're in a place where it doesn't lend itself to surgical resection. Oftentimes in the recurrent setting, there's scar and there are other things that make surgery not a viable option. When you look at surgeries that have been done on patients that have a recurrence, and this is published work by physicians who care for these patients, it's very unusual for you to get the entire tumor removed. It's typical to leave tumor around. So it's incomplete. The surgery is incomplete. And the more complete the surgery is, the better the patients typically do. The less complete it is, the worse they do. It's pretty standard. But even with a complete removal of the tumor, which is not common, you leave this margin around the tumor, which is where the recurrences occur. It's the infiltrated margin, and that can be up to about 2 centimeters around the tumor. That's not addressed by surgery, and it is addressed with what we do. So we address the tumor and the infiltrated margin, and we're getting better and better at the targeting. And the reason we're getting better and better so quickly is because every patient that we treat, we get to see the plan that we made, and we get to see the dosimetry data and see exactly where the radiation is.
Right.
And what we found in our trial so far, that the amount of radiation that gets to the tumor and how well we cover the tumor and the margin highly correlates with how the patient does. So much so that we can tell within 5 days, we can have a pretty good idea how the patient's going to do. That's very unusual system in a disease like this, that there's such a high correlation between the administered dose, the location, that you have all that data, and then you know how the patient does when you follow them.
Yeah.
So yeah, it's pretty exciting.
So when you're, you know, the radiation and the treatment goes in through the catheters and it's in the tumor, and let's say, it's working, everything's great, the tumor dies. Does it sits in your brain? Does it come out at some point? Like, what is the process if someone's like, okay, well, like now what, it's working, and let's say, like the tumor is dying off and the recurrence is fading, or I'm not sure the proper terminology of how you guys
Yeah.
would describe that, but like then what?
Yeah, so it's analogous to any form of radiation in the body to treat the tumor, in the sense that if the tumor dies because the radiation disrupts the DNA in the tumor. Tumors are very fast growing, particularly GBM. The radiation breaks the DNA into pieces. It breaks it so much that the body can't put it back together. The cell can't fix it, and the cell just kind of falls over and dies. And so that happens across the whole tumor. And so the body, it just sort of breaks down by very kind of normal processes that the body uses to break down things that aren't viable, that aren't alive. And then the body metabolizes it and breaks it down.
Interesting.
So kind of a scar is sort of replaced. The brain's version of a scar is sort of replaced there where the tumor was. So the body just invokes natural processes to clear the tumor, but the tumor cells themselves are dead. That's the key.
Why do you think there are so many challenges typically in trying to create a treatment for recurrent glioblastoma?
Yeah, so there are a handful of factors. I've alluded to some of them along the way, but let me kind of give you to you in sort of list form. So we mentioned the blood-brain barrier. Most drugs, 90%, don't meaningfully cross the blood-brain barrier. That's a big problem right there, just in terms of drugs. That includes targeted radiotherapeutics that just can't get past the blood-brain barrier. The anatomy of the brain is very unusual. So they have the ins and outs of how the brain is sort of structured, and has different anatomic layers through them. And then it's very tough to get there sort of anatomically. I mentioned surgery. So the standard by which doctors use for resection, neurosurgeons for resection of tumor, is, did I have clear margins? Did I get the tumor out? But that's only part of the problem. I mentioned this sort of infiltrative margin. You have to treat that as well. Radiation treats that, but surgery really doesn't and can't. You can't. With skin cancer, you could take a rim of normal tissue and be 100% sure really that you've removed it. Sometimes with liver cancer, a discrete liver cancer or lung cancer, you could take a rim of what looks to be normal tissue. That's why you take a rim of normal tissue, to make sure you don't leave anything behind. You can't really do that in the brain. Radiation itself is limited because of the effects on normal tissue. So external beam radiation, you have to really limit how much you can give and how you give it. Which makes it a problem. So this is kind of a new way to give radiation. So it's a new way to give radiation. It's a way to take the blood-brain barrier out of the mix. It's a way to solve the issue of the infiltrative margin on GBM. And it's a way to administer very high levels of DNA damage to the tumor, but not to the normal brain. And so our technology tends to solve all of those kind of pesky problems that have been with us as we take care of glioblastoma patients.
Talking about DNA damage, that's something that we've never really talked about on the podcast before. I'm just curious, can you talk more about that? Like, what does that actually look like? And when you're saying doing DNA damage to a tumor, for someone that has never heard that before, what does that actually mean?
In many cases, almost all cancer therapies, their efficacy meets at the point of DNA damage. What they're trying to do is damage the DNA of particularly cells that are growing very quickly. The tumor cells, generally speaking, grow much faster than normal cells. And so when you even give a chemotherapy that's not targeted, it circulates to the body, it gets into the tumor, it also gets into the normal tissues, and it has some effect. It's called a complication or called a side effect or something. But the lion's share of the the damage is to the DNA in the tumor. And when you damage its DNA, the cell can't replicate. And that's the problem with cancer cells. It's unregulated growth of cells. So if you can destroy the DNA, the cells don't grow, tumor doesn't grow, tumor dies, and then the patients do better, live longer. So radiation is a great form of treatment specifically for the fast-growing DNA. And with respect to rhenium, the isotope that we use, it sends out high-energy electrons. They're called beta particles, and it's like a bullet through a gun. And you're sending out, millions of these, hundreds of millions of these bullets, and the bullets go out in all directions, and they blast through strands of DNA in multiple places. And if they break it up so much, the body just can't repair itself and the cell dies. So it's those bullets of high energy electrons that kill the DNA. The key is to put enough of them there that you can wipe out all the tumor cells that are there. And that's why rhenium is a great isotope. And then that's why we formulate it in this way. So it puts all of the radiation there in and around the tumor, but it's not going through other places of the skull or the face, or not going to the other organs and tissues.
Do you know the story of how rhenium-186 was discovered?
Rhenium's actually it's on the periodic table. If you look at the periodic table of elements, rhenium's kind of down towards the right at the bottom. So I think it goes back kind of to the early part of last century when it was discovered, as many of the lower level elements or atoms on it were discovered. Rhenium itself is actually about 80% of the usage of rhenium that comes out of the ground. It's a rare earth mineral. It's actually used in airplane engines and the blades, that it's very heat tolerant. We make it through we don't start with rhenium, we start with something else and turn it into rhenium. And it's actually made in a nuclear reactor. So it goes into the nuclear reactor, it gets irradiated, I think with neutrons, and then it comes out as rhenium-186.
That's wild.
Yeah, it's really wild. So it's not an inconsequential thing to make. It takes a lot of scripting behind the scenes for us to make sure that dose of rhenium that's encapsulated in nanoliposomes gets delivered to the hospital, when the patient needs it. But that logistics is all in place. It just takes a phone call from the doctor's perspective or the patient's perspective.
Wow.
But the 186 isotope has a great half-life. It lasts for 90 hours. The half-life, it decays every 90 hours. Half of it decays. And it goes about 2 millimeters, which is very precise. It's a very precise path length. And it has a good radiation density and energy that makes it optimal for CNS cancers. And that's what I mentioned before. The physics are really optimal for this. So it's a really unique, interesting radioisotope.
The patients that have currently gone through the trial or that are just finishing up, can you share more about the outcomes of what the data is resulting from the ReSPECT GBM trial?
Yeah, so the way I would characterize the data that we have so far is in terms of 3 ways. One is sort of feasibility, because what we're doing is unique. Nobody's ever really done what we are doing today. This is really kind of groundbreaking. It's groundbreaking in how we're delivering it. We use something called convection enhanced delivery, which is sort of the catheter technique, and we pump the rhenium-186 into the tumor. We pull the catheters out, and then we follow the patient. So that in and of itself is incredibly novel. We also put, the bigger the tumor is, the more of fluid we put in, because we're trying to treat not just the tumor, but the area around the tumor that's at risk. So we put pretty substantial amounts of fluid with the drug so that it pushes the drug into that whole area that we're trying to treat. So that's something that, to my knowledge, nobody's ever put that much fluid safely into a tumor. So we get back to this issue of feasibility, and then this much radiation. So let me just put this in perspective for those that are listening. So in the recurrent glioblastoma patient, if they get radiation, they get about 35 gray. Radiation is measured in gray. They get 35 gray. We're delivering up to 740 gray. And typically right now in our phase 2 trial, about 300, 350 gray. So routinely, we're giving 10 times the amount of radiation. Nobody's ever given that much radiation and done it safely. So that's the feasibility is all there. The case planning and all the things I just mentioned are there. So that's kind of point number one. Point number two is safety. It doesn't make any difference if this is, nobody's ever done this before and it's 10 times the amount of radiation. It's not safe. So it's been remarkably safe. And there's been no dose limiting toxicities, which is how you measure in these kind of trials, what the maximum dose is. We haven't hit a maximum dose yet, which is incredible. We're still, the FDA, in conversations with the FDA, they've said, look, gosh, this is really promising, but you've got to just figure out what's your maximum dose. We haven't figured it out yet. So it's been remarkably safe. The catheters really aren't problems for the patients. They don't have systemic exposure to the bone marrow or other place. And they do really well. Patients often are really tired with external beam radiation. They don't seem to be tired like they are. I've interviewed some patients that have been treated. I actually ran in a 5K with one of our patients once and talked to him.
Oh, wow.
To the 5K, and he had radiation, prior to his recurrence, and he said it was great. It was really a much better experience than going in every day for radiation. So it's been safe, remarkably so thus far. And then efficacy is sort of we're still in progress. So I want to be very careful about that. But let me tell you what we've shown so far. And there's the neuro-oncologists have their annual meeting every year. It's every November. We presented our data from our GBM trial, the phase 1 and the phase 2 data at that meeting last year. And we showed in the phase 1 trial, the patients that got a therapeutic dose of radiation, and in our mind, that's 100 gray of radiation or more. Of those patients, the median overall survival doubled what standard of care is. It was over double. It was like 110% of the standard of care. So that's a big change in survival. And then some patients live much longer than that. That's just the median. And some patients had difficult tumors, difficult locations, difficult tumor geographies, or we were early in the dose escalation phase, so they didn't fully benefit. But in the phase 1, we showed that if you get an adequate amount of radiation to the tumor in the dose escalation phase, that it doubles their survival, or over doubles. So in the phase 2, we took what we call the recommended phase 2 dose out of the phase 1 trial, and we reported the first 15 patients in the phase 2, and the median overall survival was about a 60% improvement in survival. Very early in the trial, a number of patients still alive, but a very promising early overall survival signal. And just for comparison, most phase 1 or early kind of phase 2 trials that you see in glioblastoma, you're not even really looking at overall survival. You're looking at imaging endpoints or other things they're sort of proxies for survival. We actually have overall survival data here in the phase 1, which is very unique.
For those that are listening and you want to learn more about the trial, maybe to enroll, to just gather more data, what can they do? Who can they reach out to? How can they go about that?
Yeah, so this trial is actually currently funded by the National Cancer Institute, the NIH, so through phase 2. So it's in clinicaltrials.gov. You can obviously go there and see. It's called the ReSPECT GBM trial, like the word respect and the GBM after it. This started in Texas at the 3 major cancer institutions in Texas, MD Anderson and University of Texas San Antonio, and my alma mater, University of Texas Southwestern in Dallas. We're now expanding it to the Midwest, so Ohio State. So patients in the Midwest can be referred to Ohio State, and we're a center in New York, and then a center in Florida. Those will be starting kind of imminently. So patients can call us. We have a referral line, and we'll help triage, do a checklist, make sure they fit the inclusion exclusion criteria, and make sure they get into the study coordinator at the hospital that makes the most sense for them.
Well, thank you so much for taking the time to share more about what you guys are working on. I think it's super fascinating, and I think a lot of people listening to this will be able to have learned a lot, and not only just about Plus Therapeutics, but just, again, like targeted radiotherapeutics in general. And I think it's very interesting for a lot of people in the glioblastoma community to learn about the research that's being done. So thank you so much for taking the time to share that with us.
My pleasure. Thank you, Amber.
Thank you for tuning in to another episode of Glioblastoma, A.K.A. GBM. To learn more about the Glioblastoma Research Organization, you can visit us online at gbmresearch.org, on Instagram or Facebook at Glioblastoma Research, on Twitter at glioblastoma.org, or on LinkedIn as Glioblastoma Research Organization. To start your own fundraiser, to donate, or to learn how to get more involved with the organization, please email us at contact@gbmresearch.org, and we'll see you on the next episode of Glioblastoma, A.K.A. GBM.